Good morning, good evening, good afternoon to each and every one of you. We have participants from 25 countries who have registered in, and we welcome all of you. The fun part is interacting with all of you, participants as well, and learning from you. We are super excited that our final course of the 2020 series this year comprises of such an esteemed group of faculty. Let's move right in to the first session, which is tips and tricks, management of the uveitic cataract. I have no relevant financial disclosure. Cataract, glaucoma, and cystoid macular edema are all causes of blindness globally if you take them each as standalone independent entities. Those suffering from a uveitic condition, however, are prone to all three. It's a triple tragedy. And cataract surgery meant for visual improvement can lead to similar complications postoperatively, but now exponentially compounded. If not a cataract, here we have a secondary cataract with capsular phimosis, posterior capsular and intraocular lens opacification, glaucoma as well, cystoid macular edema, as well as posterior synechiae reformation. To add to this, we have numerous challenges secondary to the long-standing effects of the ocular inflammation, namely posterior synechiae, pupillary membrane, zonular weakness, pigment on the lens capsule, and an anterior chamber hyphema. Understand that if we can manage these eyes effectively, both systemically as well as topically, from the medical standpoint as well as from the ocular standpoint, these cases can be very rewarding and we can really get great outcomes. So I want to give 3 lessons that I have learned so far in my practice. Lesson number 1, not all posterior synechiae are created equal. Either they are less than 360 degrees with lighter posterior synechiae, less than 360 degrees dense posterior synechiae, and a complete 360 degrees of synechiae with or without a pupillary membrane. Here we have from the great Uday Devgan, cataractcoach.com, showing his resident how to do a lighter synechiolysis with less than 360 degrees using a balanced salt solution on a cannula. Note that it's not viscoelastic. He's gone in, or his resident has gone in through an area where there's an opening so as to be able to then go underneath the capsule and divide and break up the synechia. The beauty here of what I call the saline first, viscoelastic later technique is that you save a step. You don't need to wash out the viscoelastic and then go ahead and stain the capsule. So you can get a better stain of your anterior capsule in this way. However, if it's more dense, consider doing viscoelastic and then just washing it out. And remember, for less than 360 degrees, find the area where there is no synechiae and go in to try and start your synechial. Now, if you have 360 degrees of posterior synechiae, you have to note, is there already an opening in the iris or not? If there is a peripheral opening already in place, then you can go in through that way, inject viscoelastic, and establish your synechiolysis that way. Otherwise, you can establish a new peripheral iridectomy. Lesson number 2, control the inflammation. I love this quote by Dr. James P. Dunn from the Wills Eye Institute. You can be the world's best surgeon, but if you don't have the uveitis controlled beforehand, or you don't pay attention to controlling the uveitis afterwards, you're going to have higher chances of ending up with a bad outcome. So what do I mean by controlling the inflammation? You want to maintain at least 3 months of quiescence, control when there is no vitritis and no cells in the anterior chamber. Residual flare is acceptable, but no vitritis and no cells in the anterior chamber. Now, here's a great snapshot of the perioperative steroid regimens that you can use for cataract surgery, primarily composed of oral prednisone between 2 to 4 days prior to surgery, and then adding to that steroid injection. Controlling it, of course, postoperatively with topical steroids and cycloplegics is important, topical NSAIDs. Some surgeons actually prefer to use preoperative NSAIDs as well, and we're going to get the expert opinion. But I really am a big fan of starting oral prednisone in advance, of course, customizing it to the patient as far as whether I start it 2 to 4 days in advance or even up to 7 days in advance, and doing topical steroids in the immediate postoperatively hourly along with cycloplegics, and I start topical NSAIDs in the postoperative period. This excellent perioperative corticosteroid cataract surgery trial, the PROTECT trial, is in the works. It's a randomized comparative effectiveness trial comparing oral corticosteroid prophylaxis versus intravitreal corticosteroid prophylaxis for patients with uveitis undergoing cataract surgery. It's comparing a dose of prednisone 60 milligrams per day for 2 days prior to tapering over 2.5 weeks and intravitreal triamcinolone at the end of surgery. Super excited for the results of that. And finally, lesson number 3, we are doctors first and ophthalmologists second. Here's a patient with granulomatosis with polyangiitis. And here we're so concerned about the cataract when what he's concerned about is his pulmonary manifestations and the shortness of breath and the hemoptysis that he's developing. So a simple, John, you have so much more going on than just your eyes. How can I help? Is all it takes to develop that patient-physician relationship. And what about the patients with HLA-B27 ankylosing spondylitis with their severe neck pain and back pain? What about the time during surgery? So just a simple word of, Miss Christina, I have ordered a few extra warm towels on the day of surgery for your neck and back. Can you think of anything else that may make you comfortable? And a final example, Mrs. Smith, is there someone that can help you instill your eye drops at home? It's not just about saying that we're going to have these patients start on topical prednisolone acetate hourly after surgery, but actually looking and trying to figure out what is their obstacle in life to do what we ask them to do, and working hand in hand with them to try and adjust our recommendations to their lifestyle. Let's also remember that in addition to a good review of systems, and I cannot emphasize enough to my residents about a very thorough review of systems, that we look at the uveitis risk factors, understand systemic disease progression, medication side effects, and socioeconomic factors, especially in the municipal government hospital that I'm in Mumbai. That's critical for patient success. And finally, always engage your patient at every step. Bring them in, explain to them their risks, benefits, and alternatives, and hear them out preoperatively, intra-op, during surgery, while surgery is going on, as well as postoperatively. With that, I thank you very much, and I'm going to open it up to our faculty.
So I used to do the oral prednisone 1 mg per kg pre-op, but now it's been almost exclusively in my practice replaced by intravitreal steroids. So I'll use a dexamethasone implant in the week before surgery, unless the patient is a profound steroid responder and I'm worried about IOP. But you obviate the systemic side effects with really excellent control of inflammation, and I have no financial interest.
I guess we agree with the same things quite a bit. Like most of the time, because we are following up these patients, so they will be on the maintenance dose of steroids, unless it's a new patient where you would like to see the inflammatory control and then take up for the surgery. So they would be on, let's say, on the maintenance dose of both immunosuppression and steroids. But if it's a pan-uveitis, let's say VKH, I step up the steroids 3-4 days before the surgery and then continue. And then depending upon the post-operative inflammation, we can obviously hike up. Earlier, we used to give perioperative steroids to all the patients, but most of the time they end up having these glaucoma issues. So I guess I'm not too keen to give the periocular injections prior to surgery, but otherwise step up the topical, step up the oral, and manage the post-op inflammation.
We tend to still favor starting oral steroids, which is sort of the old traditional way, 3 days before 1 mg per kg. Although if a patient has issues with systemic steroids, which frankly many patients do, then we go the local therapy route. So I think either option is actually fine. And our preference is to give IV methylprednisolone during surgery, and the dose depends. It can be anywhere from, we don't always do the same thing. Sometimes we give 1 gram if a patient has, we're really concerned, monocular patient has had terrible inflammation. Sometimes I'll give less if somebody has intolerability to steroids. We'll do 250 or 500. less for children as well. So we don't have them take any oral prednisone on the day of surgery. We just give them intra-op. But I still am actually doing oral steroids, you know, in a JIA patient. We rarely ever use them in the care of these patients. They're not on maintenance steroids. Actually, most of our patients are not on maintenance steroids, but just for the time around surgery, you know, still really try to do that just to try to make sure that we do everything we can to minimize, you know, inflammation. And it's harder for them to tolerate injections, although you could do one during surgery. I think that could work if you don't want to be, you know, stuck on oral steroids.
And Stephen, what about the role of, you know, what are you doing in terms of your YAG capsulotomy after cataract surgery? How are you managing that in terms of the steroid regimen?
To your point about management of steroid, the risk of inflammation after a capsulotomy or a YAG capsulotomy, I would say that probably bumping up the corticosteroids in the immediate post-capsulotomy period. I tend to think that the likelihood of inflammation is pretty low in the non-granulomatous type of inflammatory process, but in patients who have granulomatous inflammation, then they need to be watched a little more closely, which actually goes back to the point about, I mean, potentially when I think about the perioperative steroid regimens, I think a little bit about, is this a granulomatous process like, you know, VKH, sarcoidosis, or synthetic ophthalmia, where maybe a higher dose of systemic steroid is needed versus something like a condition like birdshot, where I find that these patients tend to do pretty well after cataract surgery, and maybe topicals are, more aggressive topicals are important just to avoid CME, but that's just another consideration that I think of in the equation of what regimen we recommend.
Thank you, Stephen. And Dr. Goldstein, any final thoughts regarding YAG capsulotomy post-operative? How do you manage that?
Well, I agree with Stephen's point. I think it really does matter what the diagnosis is. So clearly, patients with VKH wouldn't be surprised if we see an inflammatory response. B27 patients can often get a significant inflammatory response from YAG. But again, birdshot patients, a lot of patients with purely posterior uveitis, they really do fine. We don't get much inflammation at all with it.
Oh, wonderful. So we are going to move forward to Dr. Nisha Acharya. She is a graduate of the Harvard Medical School for her residency at the Massachusetts Eye and Ear. She then went on to the University of California, San Francisco, and is currently the director of the Uveitis Service and of the Uveitis Fellowship. And we have a few of her fellows with us as well today, so welcome to them. She has been involved in multiple different trials, and she has done significant amount of work in terms of the herpes zoster vaccine and its impact on herpes zoster, as well as herpes zoster ophthalmicus. So without further ado, I hand it over to Dr. Acharya to give us inside and out herpes multiple choice questions.
Thank you for the really nice introduction. And I have to say, this is a great idea that you put together during the pandemic. It's really brought people close together. I'm gonna have a few questions related to herpes. That's what I was asked to speak about. And it's a topic that's always interesting, right? Because it can affect any part of the eye. Okay, so first question. What condition is this clinical picture most consistent with? This is a patient from Proctor where I practice. It was taken by Todd Margolis when he used to be there, because we have many patients with photos, but he was probably still the best photographer that we had, and he's now moved to a different institution, but I love this one that he took. So take a look at this photo closely. It's of the cornea, and what do you think this condition, this kind of picture is most consistent with? A, herpes zoster anterior uveitis, B, cytomegalovirus anterior uveitis, C, herpes simplex anterior uveitis, and D, Epstein-Barr virus anterior uveitis.
Okay, so the first question goes to Dr. Fatima Zagwa from Northwestern.
So just by virtue of elimination, I would say this is probably more consistent would be CMV anterior uveitis.
Yes, that is correct. Very nice job. A lot of people have never seen or heard of this actually when we talk about it. So that's excellent that you were able to recognize this picture. A little bit more into the corneal findings in herpetic anterior uveitis, which encompasses all the, many different viruses, HSV, VZV, CMV. Some of the things about the cornea are that, that the chorotic precipitates are often, or commonly in my experience, and I think most people's experience, diffuse. meaning it's not that they're not just an Arnold's triangle. So that can be a clue. But the KP can have varying morphology, and that's what's so interesting. You know, even within CMV or within HSV, they may be stellate, pigmented, mixed size. But if you see these kinds of circular endothelial deposits, that is really characteristic of cytomegalovirus. So if you don't see those, it doesn't mean it's not cytomegalovirus anterior uveitis, but if you do see those, it's a very nice clue. And you can also have accompanying endotheliitis because of the corneal involvement in any of these forms of herpetic anterior uveitis. So this is just a closer view. You can see these kinds of, there's different names, circular or corral shaped, circinate pattern of these deposits on the corneal endothelium, which is seen in CMV. But this is another patient with PCR proven, these are all PCR proven cases, where you have more of a stellate appearance, but they are diffuse, as you can see. They're going all the way up the cornea, just to show that we don't always see the same pattern. This is a PCR proven HSV, herpes simplex virus, and this has this kind of pigmented, but there are some up here on the cornea, but these kinds of mixed size, some people would call them sort of granulomatous, but they are pigmented and mixed size, some of them being very large. So which of these would be most beneficial for a patient with the following? A, send ocular fluid for viral PCR testing. B, send ocular fluid for viral PCR testing and inject antivirals. C, send ocular fluid for viral PCR testing, inject antivirals, and start systemic antivirals. D, send ocular fluid for viral PCR testing, start systemic antivirals, and systemic steroids.
In my opinion, it should be D.
So yeah, so this question can be a little bit tricky, and I put it in even knowing that there may be a little bit of a disagreement or thoughts on the answer. The answer that I personally was thinking was the answer in my mind was C, although I think some people would perhaps choose D. But I had put down send ocular fluid for viral PCR testing, inject antivirals, and start systemic antivirals. So let's talk a little bit about that. So this is acute retinal necrosis. That's correct. And the American Uveitis Society has criteria on what this condition is, which is that it's where you see at least one focus of retinal necrosis with discrete borders in the peripheral retina. There's rapid circumferential progression of necrosis in the absence of antiviral therapy. So all of those kinds of peripheral retinitis will eventually coalesce. There's evidence of occlusive vasculitis with arteriolar involvement, and then prominent inflammation in the vitreous and anterior chamber. And you can actually see that I think most of these are present here. All of these peripheral lesions will coalesce eventually. You can see they're circumferential. The arterioles are involved here. You can see that they look pretty occluded. But let's just focus on treatment here. So there's some differences in treatment, depending on where you practice, but everybody believes, I think for the most part, that the treatment of choice should be systemic antivirals. And IV acyclovir is the traditional treatment, but there are some options for high dose oral, such as Val acyclovir 2 grams 3 times a day. That can be an alternate to intravenous. You have to watch the renal function, but that I think is pretty much a consensus that we prefer using systemic antivirals. Intravitreal antivirals, there's not a clinical trial showing that they are of added benefit, but there's a number of studies showing that injections and even repeating them may be of benefit. And that can be with foscarnet or again cyclovir. And those can be repeated even every few days until the situation stabilizes or the retinitis is under control. There is a preferred practice pattern from the American Academy of Ophthalmology on ARN. And they mentioned that systemic antivirals plus intravitreal are beneficial, but specifically with the systemic steroids, their recommendation is that so far that the evidence is that they should not be used until appropriate antiviral therapy has been initiated. So it wouldn't be something that you would do on the first day that you see a patient. And it doesn't really say exactly when it should be instituted. I think, I personally will do 48 to 72 hours. Sometimes it's longer, it depends on the patient. And we can hear from the panel because there may be differences among us, but I wanted to just bring the attention of this AAO preferred practice pattern and the idea that you have to be careful with systemic steroids because this is a very dangerous, infection and it can spread rapidly, and steroids can have a role, but it's really, in my mind, important to make sure that we have a good hold on the infectious component. PCR testing is, optional, but can be very helpful in identifying the virus and sometimes confirming, and so we usually do it, but it's not mandatory.
Dr. Goldstein, any thoughts on this?
Yeah, so I use everything that Dr. Acharya talked about. So I'll use Valtrex 2 grams TID. I only use IV antivirals in patients with either no insurance or terrible compliance, so that I know that they're getting the medications. I do intravitreal antivirals for anyone in whom I think they're anything threatening the macula or large areas of involvement. I don't start steroids systemically until I think that I'm getting control of the virus. So certainly I've seen patients where the disease diagnosis is very delayed. They've got 80% of their retina involved. So we have a trade-off. I want steroids to hopefully decrease the chance of vitreous bands, which would cause vitreous traction and result in detachment, but I'm more worried about control of the virus initially. I do repeat intravitreal antivirals until I feel like I've got control. I think that, that these patients all do need to be treated with systemic antivirals. You can get nice control locally with intravitreal, but it is a bilateral disease, or maybe a bilateral disease. It's a systemic disease. You need to treat them systemically.
Dr. Vishali, any points?
I agree with Deborah. The main purpose is to protect the opposite eye. So systemic for me would be the first thing to start. Intravitreal, if I feel required, not for all patients. Steroids 48 to 72 hours later. But I would also give aspirin because many of them develop the occlusion of the small vessels. So the baby aspirin is also added.
Moving on, so what phenotype is consistent with a herpetic anterior uveitis? A, painful red eye with relatively low intraocular pressure acutely. B, recurrent anterior uveitis associated with elevated eye pressure. C, chronic anterior uveitis with high pressure. And D, B and C.
The answer might be D.
Okay, excellent. Yeah, that is correct. Very good. So this is, herpetic anterior uveitis has many different phenotypes, and herpetic again can, encompass HSV, VZV, and CMV. So there are many different presentations clinically. So just to review a bit about these, so the anterior uveitis can be from simplex, zoster, or cytomegalovirus. Typically, these are in immunocompetent patients. Usually they're unilateral, but they can be bilateral. There is an association with atopy. So if somebody has a history of allergies like asthma, eczema, because there's a reduction in cell-mediated immunity with that, that can also predispose you to herpetic anterior uveitis. Most of these patients don't have pain or sometimes minimal symptoms, but some of the clues as to this being herpetic are increased intraocular pressure, iris changes, including atrophy or loss of anterior brush border of the iris, irregular pupil, so a larger pupil or irregular pupil. And the course, the uveitis course can be acute, such as a glaucomatous-cyclitic crisis type of picture, where you have sudden increase in high pressure and a little bit of inflammation, but in between these episodes, patients are fine. And it can be one or more episodes, so acute or recurrent, or it can be more of a chronic picture with smoldering, just ongoing inflammation with high pressure. And we'll see that sometimes in CMV or the other types of herpetic anterior uveitis. So either one of those. So you got it exactly correct there. So which of the following will treat CMV anterior uveitis? A, valacyclovir, B, valganciclovir, C, letermovir, and D, B and C.
Good to meet everyone. Thank you for having me. I believe for anterior uveitis, we typically start with A, valcyclovir. Of course, it depends on whether we suspect HSV or VZV in terms of the dosing.
So what about if it's CMV specifically? CMV anterior uveitis, would you start with that?
I think, it depends on if the patient is suspected for immunosuppression and whatnot in terms of CMV. Of course, I have personally a little bit less experience with that. I think it would be reasonable to still start with Valtrex initially, but I think valganciclovir would be the more sort of primary treatment for CMV, I believe.
It's a little bit tricky because In terms of what most people would do, I think the answer is B, valganciclovir systemically. We'll talk about A in a second here, but there is a new medicine that is an alternative called letermovir, so I just wanted to introduce that. It's not as commonly used, but in terms of what would actually has efficacy against CMV, it's actually B and C. So let's talk a little bit about treatment of CMV anterior uveitis, and I'm focusing on that because I think that's people are less familiar in general with this, because it's, even when I was, I think, in residency, I'm not sure we even were that aware of this condition. It's recognized, kind of relatively late in ophthalmology, but we realize that it's a fairly common condition, especially in Asia, but we see a good number of patients here too with this. So CMV anterior uveitis. So the antivirals of acyclovir and valacyclovir and famciclovir do not work. They're not effective against cytomegalovirus. So if you think it is CMV or you have a PCR proven case, then we would choose to use an antiviral that we think is effective against that, and that's valganciclovir, or Valcyte is the brand name. And so systemic valganciclovir, it's the induction dose, which is what was used, for CMV retinitis, and it's 900 milligrams twice a day. And we like to keep it on for at least a couple of weeks, but really it can be longer, until the uveitis is better. And then you have to decide, do you try to come off of antivirals or do you maintain them on a prophylactic maintenance dose? It's really important to monitor complete blood count and renal function, because you can have abnormalities in both, including decreased white count and decreased pancytopenias, really. So that requires closer monitoring than you would with other antivirals. Systemic letermovir is a once-a-day daily drug, and it's relatively new. It got approved in the bone marrow transplant population for CMV, systemic CMV. And it has a much better side effect profile in terms of there's not really issues with cell counts or renal functions, so it is an alternative. Other alternatives are intravitreal therapy, ganciclovir or foscarnet, topical ganciclovir at 0.15% or higher concentrations we sometimes use, and then low-dose topical corticosteroids in conjunction. So just to mention this new medicine, letermovir, there was a paper from our group. Edmund Choi was a fellow at the time, and he's at UCLA now. Thuy Doan was a senior author here, and I think started using this medicine, but we all have patients now that are on this who had failed valganciclovir. And this was a small case series of 6 patients, but they either had side effects or things with valganciclovir, and they all did well with control of inflammation on letermovir. So just wanted to bring that to everyone's attention. Which of the following is true of herpes zoster ophthalmicus? A, incidence is decreasing. The incidence of HZO is decreasing in the past decade. B, most patients getting herpes zoster ophthalmicus are older than 70. C, the incidence is increasing in the past decade. And D, the herpes zoster vaccine has a vaccine efficacy of approximately 50%. Yeah, that is correct. So very nice job, everyone. So just wanted to kind of talk a little bit about what our current knowledge of herpes zoster ophthalmicus is. So our group did a study actually that was published in Ophthalmology earlier this year, looking at the incidence of herpes zoster ophthalmicus from 1994 to 2018. And we used a very large insurance claims database that had, just millions of patients across the United States with commercial insurance and then also Medicare. And basically we found that the incidence it's continued to increase every year. The average rate of increase per year is about 3.6%. Very tight confidence interval between 3 and 4% per year. There have been, I think the Michigan group has not published yet, but they had presented at ARVO similar results showing continued rate of increase. And herpes zoster is also known to be continuing to go up for decades, even until current times. And so it's really something that's a pretty major issue actually, that it keeps on going up. So just wanted to let everyone know that it's still going up. There are some interesting trends though. So, and so if you look at over time from 1994 to the current time, and you look at incidence by age group, so 10-year age groups, it is going down in the oldest groups, in the 70 and 80-year-olds actually, but it's increasing in what we call, I don't know what the right word is, the middle age groups, the 40, 50-year-olds, and it's going down in the very young It's going up in this group that I think all of us, some of us on this call are. I don't think we have anybody in the oldest group, so I'm going to go ahead and say that. But some of us in this meeting are in this group, and we're not in the group that's eligible for the zoster vaccine yet. Well, actually, we are getting close, but it's 50 and above. But very few people get vaccinated at 50 and above. Most are older. And so I think
for us, insurance was only covering it for patients over 60, which makes no sense at all based on your data, which shows that it's younger people who are getting it. So
yeah,
I
the highest prevalence now,
50th birthday present.
Yeah, so I think that really the highest risk now is in the 50 to 60-year-old range, and not the 60. I mean, you still have obviously lots of people getting it when they're older, but I think that there is this issue. And just that there is a good vaccine now. So the recombinant zoster vaccine, or Shingrix, got approved at the very end of 2017. It's not a live vaccine. It does require 2 shots. The efficacy is in the high 90% for preventing herpes zoster. And we have preliminary data from our group that it's equally as good, if not more, for preventing herpes zoster ophthalmicus. And the older vaccine, Zostavax, was only 50% effective, not in the 90s. So that was not great. But now we have one that is better. And the FDA has approved this, and the CDC recommends this for ages 50 and above. And the AAO has come out strongly saying that they believe that everyone 50 and above should be vaccinated with this new vaccine because it's more effective, and we think the immunity lasts for years. And so hopefully if you get vaccinated, you won't need to get revaccinated, although there's no long-term data on this. I've seen, there are many people, including medical professionals, that have lost vision, significantly, or because of this preventable disease. Mm-hmm. So now we have a vaccine. I think I just wanted to put a plug in for ophthalmologists trying to promote vaccination in patients who aren't vaccinated. So in summary, herpetic anterior uveitis can be caused by simplex, zoster, and cytomegalovirus. Think about it. If you see diffuse KP, increased IOP, iris changes like atrophy or dilated irregular pupil. Acute retinal necrosis requires prompt treatment with, I would say, systemic antivirals. There are adjunctive therapies as well, but systemic antivirals. And herpes zoster ophthalmicus is continuing to rise, so we should be on the lookout for it, especially in younger patients. And we also have a role in promoting vaccination, I think, in the public health sphere.
So I have a question for you, Nisha. What do you do in terms of recommendations for vaccination for someone who's already had zoster, anterior or posterior uveitis? That's the $1 million question, right?
Yeah, no, you're asking, of course, the hard question. I don't know. We're actually looking at this. It's really hard to look at it with databases because, you look at people who have a diagnosis code who are on treatment and then you get vaccinated. I'm trying to compare their outcomes to people who didn't have the disease. The CDC says that everybody who has even any form of zoster should get vaccinated. I don't know that we don't have data to support that yet. I wouldn't do it in the acute situation if somebody has active inflammation, but I think the question still is out, is if you've had it, or you have chronic controlled disease, is there a benefit or harm of getting vaccinated? There's some reports of increased inflammation, right, which potentially could happen. So I don't know, I'm interested in your thoughts. Right now I am asking patients to get it if it's been a remote history and they're under good control, but I'm trying to look at this question.
So I'm waiting for your data. Okay. The problem is somebody with difficult to control inflammation. I ask them not to, but if it's been a while, then I say, go ahead and do it to protect your other eye, protect your body. But I think that's something that we really need data for.
Yeah, it may be hard to answer. We're going to try, but it's hard when you don't have, that may be a good answer with detailed records, and that's not always the case, right, with large. Yeah. And somebody's asking, is universal recommendation for VZV? So that's the chickenpox vaccine, which started pretty late, like in the 90s. So, most of us that are older all got chickenpox. And now kids get vaccinated in some countries for chickenpox. But actually, everybody's still at risk for zoster because the chickenpox vaccine can stay dormant in your, latent in your body as well. Most of those people are still pretty young individuals, so they're not in a high risk category for shingles yet. All of these vaccines that have been introduced are maybe changing the epidemiology. And there's less immune boosting now because we don't see kids with chickenpox. And so us adults getting older now, maybe higher risk of zoster.
So Dr. Goldstein is a personal favorite of mine. I'll tell you why. I was a resident at the University of Chicago way back when, and I will never forget, if I close my eyes right now, I'll never forget her on the podium with the passion, the energy that she has. She is professor of ophthalmology at Northwestern, and she was titled this year by the American Academy of Ophthalmology as one of the 2020 unsung heroes. And I think more than reading off her CV, this quote that I came across, I think is so perfect. So I would love to share that. It says, quote, "Passionate, energetic, and demanding in equal measure, Dr. Goldstein is a hero to her trainees, colleagues, and patients. To her trainees, she's a life-changing mentor. To her colleagues, she's a brilliant detective sleuthing out differential diagnoses. To her patients, she's a miracle worker who truly cares." And another quote, "She has a larger-than-life personality and a brilliant teaching style." I am absolutely grateful and honored that she is with us today to give us her pearls on imaging modalities.
Okay, that was the night in my entire life. So now I need a Kleenex. Okay, thank you so much for inviting me. My original topic had been to look at what was new, what the new techniques are in 2020. And I spent a lot of time thinking about what I wanted to talk about. But I realized that even though I'm at an institution that has every toy in the world, I don't use most of those. I still stick with things like OCT and fluorescein. So what I wanted to do is actually show you just some maybe different ways to use techniques that we all already have. You know, I do use OCTA, but yeah, more for research than clinically. So I have no relevant disclosure. I'm going to do this with cases because that's how I always teach. So our first case is a 41-year-old woman. She's an engineer, and she's self-referred because she's miserable. She's been treated intermittently with periocular injections of steroids when she gets CME. But she says that her vision is terrible even when her OCT is fine. Her best corrected acuity is 20/20, but she is miserable. She has 2+ anterior vitreous cell in both eyes, no haze, no clinical vasculitis, and workup is unrevealing. So this is a montage that I put together just showing you that she doesn't have significant haze and has no visible vasculitis. So here's her OCTs, and the OCT of the right eye looks really normal. And the left eye, we just see a little bit of cystoid macular edema. But I want to tell you that if you stop here, you're really missing 99% of her story. So first of all, you can just click on the little button that shows you retinal thickness maps. And this is kind of a poor man's fluorescein. So anybody who is doing OCT can get a retinal thickness map. And you can see here that the retina is much thicker than we expect, and there is thickening around the vessel. So this tells us that there's probably vasculitis. So we do a fluorescein, and the entire retina is sopping wet from the disc to the aura. In fact, there's angiographic CME in the right eye that looked normal on OCT, but the entire retina is wet, and her left eye has extensive vasculitis, much more so than we expected from looking at her clinically or from the OCT. And I can tell you that after trying 3 different immunomodulatory agents, I finally have her retina dry. She is still 20/20 in both eyes, but very happy with her vision. Our second case is a 36-year-old woman referred by a retina surgeon. She's been diagnosed with CME in her right eye secondary to vein occlusion. She's had 6 anti-VEGF injections, and then she develops anterior uveitis in her right eye, which was felt to be secondary to one of the anti-VEGF injections. So she's treated with topical steroids, and then they go back to the bevacizumab every month. And then she develops macular edema in her other eye, so she's sent to me. So her best corrected visual acuity is decreased in the right eye. It's normal in the left eye. She has anterior chamber and anterior vitreous cells in both eyes. So this tells us right now we're not looking at CME from a vein occlusion. She has no clinical vasculitis and certainly no evidence of a vein occlusion. So here's the posterior pole fluorescein lates, and this was the most leakage I could come up with on this. And you could see that there's a little bit of CME in both eyes. But again, if this is all we're doing, we're missing 90% of her story, because here's the wide field fluorescein, and you could see there's extensive vasculitis in both eyes. So this is intermediate uveitis with retinal vasculitis. She never had a vein occlusion, and this is the cause for her cystoid macular edema. So here, the wide field fluorescein shows us a lot more than we saw on the posterior pole fluorescein. Our third case is a 29-year-old male with bilateral anterior and intermediate uveitis and neovascularization of the disc in his right eye. And this is presumed to be secondary to tubulointerstitial nephritis and uveitis. So you can see on our fundus photos, he's got NVD in the right eye. And if you take a look at the fluorescein shows us very nicely the neovascularization of the disc. And then you can see in the peripheral images, he's got retinal vascular leakage, he has vasculitis, but there is no ischemia. So here, fluorescein very helpful, the fluorescein confirming that he has NVD, defining the NVD, but very importantly, we don't see any ischemia on the peripheral fluoresceins. And I can't tell you how many patients I've had who've come in with extensive PRP for inflammatory NVD. So not all NVD needs PRP. This guy, the NVD goes away completely with steroids and immunomodulatory therapy, and we haven't lasered his retina. I have two more quick cases. The fourth case is a 28-year-old woman with PIC, and she comes in with new photopsias in her left eye. The clinical exam doesn't show anything new, so she has her stable PIC lesions. The right eye has decreased vision because of an old net. The left eye is 20/20, but this is the one that's got new photopsia. Here, wide field fundus autofluorescence is extremely helpful. So on the left eye, we can see these hyper autofluorescent lesions throughout. So not just in the area of the lesions, actually mostly not in the areas that we would image with standard OCT, showing some diellipsoid here outside of the area of her previous lesions. So she got treated with an intravitreal dexamethasone implant, and here's her autofluorescence images 5 weeks later, and you can see there's resolution of the hyperautofluorescence. And you can see on the OCT, she has reconstitution of the ellipsoid in those areas. Our next case is a 35-year-old woman, also with PIC and also with new photopsias in her left eye. Her examination is really unremarkable except for some old PIC lesions. And she came with an OCT just of the fovea that was completely normal. But here we can look at her fundus autofluorescence. And again, you can see extensive hyperautofluorescent lesions, in this case, mostly nasally. And here's OCT through that area, and you can see there is segmental or patchy loss of ellipsoid in the hyperautofluorescent areas. And here she got put on oral prednisone, and you can see the autofluorescence has recovered completely, as has the OCT. We had patients with PIC with new photopsias. They all had these areas of regional hyperautofluorescence only in the symptomatic eye. In all cases, there was matching ellipsoid zone loss, but very often they had had normal OCTs of their fovea because the fovea wasn't involved. They all had resolution of symptoms and imaging abnormalities with either regional or systemic therapy. So we really believe that all uveitis patients with new visual symptoms should have wide field fundus autofluorescence. There's a really exciting new imaging that's coming out, but we all, or almost all, I think, have access to OCT and fluorescein. So OCT, really helpful. Retinal thickness maps are really useful. You've got the data there already. You can click on your little button that says show thickness maps, and you can get an idea that even if the OCT looks normal, there is retinal thickness, and you can actually do OCT in other areas and kind of put together a poor man's fluorescein angiography to see that there's thickening around the vessels. Fluorescein angiography still extremely helpful. You saw in the first patient I showed you, imaging with OCT was really not that exciting, but very impressive fluorescein leakage. Wide field fluorescein angiography is really invaluable, with the caveat that I don't make treatment decisions on leakage that's only in the far periphery, but you can still see mid-peripheral and relevant peripheral leakage on wide field fluorescein. And fundus autofluorescence is a tool that we didn't have when I was training. It's extremely, extremely helpful.
So I have a question. If you had the option to choose any toy in the world that you don't currently have, which one would it it be, and how would you use it and why?
So what I really using AOSL ophthalmoscopy to try to get cell counts, like the equivalent of endothelial cell counts. I wanted photoreceptor cell counts. I would like to be able to look at rod and cone density in the retina, because when we get an OCT, we can say the ISOS looks fine or it looks ratty, but we really can't quantify it. So for diseases like birdshot, for diseases like autoimmune retinopathy, whatever that is, I would really like to get an idea of what my actual photoreceptor cell density is, and we can't do that. So I tried for years to do AOSLO, and I could only get good imaging on patients with absolutely perfectly clear media and perfect fixation, which eliminates all of my patients. But I think sometimes we have patients who tell us that they're getting worse and their imaging is the same, but you know, how do you quantify rattiness of photoreceptors on OCT? That's really what I would like for the posterior segment.
And a question has come in from Dr. Honda, who's a fellow. Is the thickening due to leakage?
Yes, that's the short answer. Yes, because if you do fluorescein angiography, you'll see diffuse leakage in almost all those cases. I mean, certainly you can see thickening in infiltrative diseases, right? Like in primary CNS or primary vitreoretinal lymphoma, you'll see thickening, but the clinical picture is very different.
Hi, Deborah. That's a really good talk, and my favorite always case-based presentations. So just a question, what I believe too is that we need to do fluorescein angiography besides OCT in patients where we don't see anything, and that's what we are seeing, diffuse leakage. So how often do you repeat fluorescein angiography once you start the treatment?
That's a great question. So if I see, and I actually just could have showed you pictures of that first patient I showed you. So I started her on adalimumab, and 3 months later I did a fluorescein, looked exactly the same. So I gave her 3 months, because 3 months of adalimumab should give you a really good effect. So then we switched her to infliximab. 4 months later, I do a fluorescein. She looks exactly the same. So then we switched her to tocilizumab, and 4 months later, she's finally dry. It looks beautiful. Once she's finally dry, if she doesn't have any symptoms, I'm only going to repeat the angiogram every year just to make sure I'm not missing something. I definitely will repeat an angiogram after I've started therapy. I think that for drugs that work fairly quickly, like the biologics, you could probably do an angiogram earlier than 3 months. But if I do one at 2 months and she's 60% better, then did the drug fail? Did I do it too early? So I kind of wait 3 months to see.
And how about the where you have retinal vasculitis? Let's say this was intermediate uveitis. So we have the obvious retinal vasculitis where we have these NVE, NVD, or we're giving. So then what is your regimen? Then how often do you do in those cases?
If I have clinical vasculitis that I can see, then I don't do angiograms nearly as frequently. So it's for me, it's most helpful to repeat them in patients with intermediate uveitis and small and medium-sized vessel vasculitis where we can't see it. But in a sarcoid patient with large vessel vasculitis, if I can monitor the vasculitis, I don't do the angiogram as frequently.
And I just wanted to add, in addition, sometimes, you know, after 1.5, 2 years, everything looks great, and this is the time you want to start your immunosuppression. I do to check any subclinical disease on fluorescein angiogram before I stop my immunosuppression in these patients.
Absolutely, I agree 100%.
So Deborah, this is Nisha. So what about if you just see peripheral vascular leakage? You know, maybe it goes a little bit posterior to the equator, but basically it's, you know, and otherwise everything looks good. There's no macular edema. Do you just follow that, or what do you think?
So I divide the retina up into ROP sort of like zones, zone 1, zone 2, zone 3. So if there's leakage only in zone 3, only in the periphery, I'm fine watching that. But once it starts moving posteriorly, that's seeing retina. So then I'm more likely to treat it. We don't have any data at all yet. We always look to you for data, but we don't have any data that says that treating far peripheral vasculitis makes a difference. To be honest, we don't have great data that treating posterior pole subclinical vasculitis makes a difference. We all do it. Every once in a while, I look at a patient and I'm like, why the hell did I do this fluorescein? I wish I hadn't done it because they're clinically great. Their OCT looks great. They have no complaints. I don't know why I did this fluorescein, and now I have to talk to them about therapy. I know that before I did this, because I've been practicing for almost 30 years, that I had patients with pars planitis that I didn't do fluoresceins on. They are 25 years later, they're still 2015 or 2020. Their photoreceptors look perfect. And maybe they had 10 years of subclinical vasculitis that I didn't know about. So I don't even have proof treating posterior pole vasculitis makes a difference, but I always will. Zone 2, I usually will. Zone 3, I follow. But this is a gestalt based on nothing, except for 25 years of treating patients. So I think we don't have data.
Stuck. We feel, so many fall in that category, actually,
yes.
And we just don't know.
And to ask that question from the other side, like when you're treating these patients, is your endpoint always a completely dry retina? Or are there some in which there's going to be chronic leakage?
I think there's some patients that no matter what you do, you can't get it completely dry. So the first patient that I show you that I was so happy with tocilizumab, she still has a little teeny bit of leakage, but she went from a completely wet, disgusting dish sponge of a retina to mostly dry, and it's the best I can do. If you have someone on, let's say, 15 milligrams per kilogram of Remicade every 4 weeks, or you have them on full dose tocilizumab and an antimetabolite, and you have a teeny tiny bit of leakage, you have to weigh the risks and benefits of escalating therapy. I think that we can't always get everything perfect.
So what is your indication to do when it's still we are learning for Octa? So what are the conditions where you think you're doing?
Where would I do OCTA rather than regular angiography? Yeah. So I find that OCTA is useful sometimes when I see a patient and I'm not sure if the little tiny lesion they have, let's say in PIC, is an inflammatory lesion or a net. But even then, it's not always helpful to me because then there's ones that I'm sure clinically is a subretinal neovascular membrane and I don't see it on OCTA no matter what I do. I still think OCTA for me is really good for research papers. Clinically, it's not as useful as I would like it to be. Takes a long time for me to go through the images, and if I have a huge clinic, I can't do it in the middle of, I still get stuck. People sometimes follow OCTA to see if their net got better, but you're gonna see that lesion on OCTA forever, so I don't think it's helpful to follow. So I really think that for me, OCTA hasn't been as helpful clinically as I would have liked.
How about you, Nisha?
Yeah, I don't know how to interpret it. We see dropout in these, we do it out of interest to see how much dropout there is in these areas. And if we see it before we see like a choroidal lesion, I don't get it routinely because I don't know how to use it yet. I'm just not there yet to know. I find it interesting to include and look at, but we've done it in some patients with serpiginous choroidal retinopathy to follow. And sometimes you think you may see dropout before you see, an actual lesion or something happening, but we're not using it really for the most part clinically.
The one thing that I would add, I completely agree with what Deborah had mentioned about PIC CNV versus PIC inflammatory lesions, that it can be helpful for that. And then sometimes I find that patients will be I find these are super duper in their observations, and it'll be like a paramacular type lesion. And then so it does take time to go to the machine and look to see where the lesion is. But then for if you are getting OCTA, I mean the 6 millimeter by 6 millimeter cube seems to help. But I mean, I'm interested down the road. I mean, whether when we look at wide field OCTA, is that going to be another sort of researchy tool, or how applicable is that going to be in clinical practice? And Deborah, I really appreciated your answer on the different zones. I think I'm going to start using that as sort of my benchmarks for patients. That's such a critical question, right? Like, I mean, how aggressively do we treat? How much patients are tolerating their systemic or their local side effects, whether we want to be more aggressive or not. But that's a great point.
In practice, OCTA angio helps to me in two circumstances. One is to identify the new vascular network, which we see a lot in patients with TB serpiginous-like choroiditis, which is a VEGF-driven disease. Now, the patients are scarred and they complain of metamorphopsia. And you do fluorescein, you do OCT, there is no fluid, but the patients are very adamant that I have metamorphopsia. And you do OCT angio and you see this beautiful network. And we are in the process of defining the subclinical before they become exudative, but giving an injection makes a lot of difference to their symptoms. And secondly, in acute VKH, to look at the choriocapillaries, the areas of flow void. The patients in VKH, the moment you start giving steroids, the fluid disappears, the vision goes very good, OCT appears very good, but those areas, they still take some time to go away. So when those areas go away, that is the time when the steroid should be reduced. And in our experience, it takes about 12 to 14 days for them to go away. And the third is the TV granulomas, where you can actually see the intragranuloma new vascularization. And that's time when we decide to add an anti-VEGF to them. So this is where I use in my busy clinical practice.
Beautiful, beautiful. What a discussion. I love it. Thank you, Dr. Goldstein, and thank you to our
pleasure.
You know, we look at the outer eye, right? We are all about these two eyes and what's going on. If you take the theme of lessons, there's so much that we've learned about life in the course of these past few months, this year in COVID. And if we really take a few moments and close our eyes, we may start to find that we actually get many of our lessons, life lessons, answered just through that silence. And so I encourage you to close your eyes and go within with a guided meditation by my best friend, who was titled Saint of the Century, Dada J.P. Vaswani. I hand it over for Dada J.P. Vaswani's Inner Sight Relaxation.
Meditation is the key to living a more rewarding, fulfilling, peaceful life. It helps you discover who you really are and what your true potential is. It enhances your ability to face life and its challenges. Meditation is not strenuous or difficult. It is simple and life-changing. The positive energy and healing vibrations of group meditations are tremendous. The force of group meditations has a great impact on every member of the group. Meditation begins with relaxation. Most of our time we are tense without realizing it. We need to relax consciously, allowing the stressed out and exhausted mind to rest. There are many ways of relaxation. Each one of us must follow the one that best suits him or her. I will but indicate to you today one simple method. Sit in a comfortable posture with the back straight as far as possible. Let the back, the neck, and the head be in a straight line. Close your eyes and take a deep breath and exhale. Do this a few times. Let your face wear a smile. Now sit still and breathe normally. Imagine yourself in the loving, the immediate, and the personal presence of the Lord, your beloved. You are sitting at his lotus feet, your arms around his ankles, your head resting on his feet. Say to yourself, here is true rest. Here is true relaxation. Now, relax the body, every muscle of the body. To relax a muscle, you must first tighten it and then release it. Remember, in immediate presence of God, we will now move from one limb to another by tightening it and then releasing it. Let us begin. Bring your attention to your feet. Tighten and relax. Legs. Tighten and relax. Buttocks. Squeeze tight and let go. Abdomen. Tuck it in and relax. Chest, expand and relax. Shoulders, lift them upwards and drop them down. Raise your arms and drop them. Turn your attention to your neck. Gently turn it from one side to another. Arms stretch tight and relax. Hands tighten into fists and relax. Relax, relax, relax. Let go, and let God. Now tighten your whole body and relax. Repeat this 3 times. Take a deep breath. Allow your stomach to expand. As you breathe in, hold the breath for a few seconds and then breathe out through your mouth, allowing your body to completely relax. Now rub the palms of your hands together and gently, very gently, place them on your eyes and open them. Continue to smile. Thank yourself for this beautiful gift of a few precious minutes of peace. Slowly turn your gaze around and become aware of your surroundings. This is the end of the meditation. Om Shanti, Shanti, Shanti.
What I have learned in doing this over the course of 2020 is that there is so much more than what we learn in ophthalmology. And the lessons that I have learned and taken away from this course has been phenomenal. But the lessons that one can learn daily within yourself perhaps can be so much more than what words can do justice to. So I thank you for taking time out of your busy schedule to do that with me. We are going to move forward to a much awaited segment, White Dot Syndromes Made Ridiculously Simple, by Dr. Stephen Yee. Dr. Stephen Yee is the M. Louise Simpson Professor in Ophthalmology and the Director, Section of Uveitis and Vasculitis at the Emory Eye Center. He serves on the Ophthalmic Technology Assessment Committee and the Uveitis Knowledge Base Panel of the American Academy of Ophthalmology. He is the recipient of the Heed Ophthalmic Foundation Fellow, the Ronald G. Michaels Fellowship Award, and the Honor Award from the American Society of Retina Specialists.
Yeah, thanks, Ashiana, for that really super kind introduction. I've got to say that the creativity and the importance of what you're doing for education for, as you mentioned, 25 countries and different trainees is really, really wonderful. So thank you for the invitation. This talk is actually going to really complement Dr. Goldstein's talk just that we had just a few minutes ago. I'll talk a little bit about white dot syndromes made ridiculously simple. I'll show some more typical and a few atypical cases based on some principles surrounding imaging as well. So Deborah talked to us a lot about some of the imaging techniques that we're using, and this is what really brings home the points related to the clinical findings and a lot of the pattern recognition that we think about in relationships to these white dot syndromes that can be very I remember as a resident that these were always sort of confusing. They kind of melded together. And so we'll be talking about some of the imaging characteristics and disease features that really help to separate them in clinical practice. And again, imaging definitely has a very key role. And the first question is, which of the descriptors is incorrectly matched? So incorrectly matched with the disease course and laterality. A is AMPI, or acute posterior multifocal placoid pigment epitheliopathy, bilateral and typically monophasic. B, serpiginous, bilateral, marked by disease recurrences and progression without immunosuppression. If you don't have immunosuppression, then patients may have disease recurrences. C, birdshot, a bilateral condition, nyctalopian visual field loss without immunosuppression. And D, mudes, bilateral persistent yellow spots without immunosuppression. So which of these is incorrectly matched? This is a multi-part, multi-understanding question.
Dr. Amit Reddy from UCSF, who is Dr. Acharya's fellow. Dr. Reddy, will you give us your best guess on this question and take us through your reasoning?
Yeah, so I think the correct answer would be D. Mutes typically think as being unilateral and then generally self-resolving without immunosuppression.
Yeah, thanks. And that's exactly right. And so this is Dr. Reddy's showing just a knowledge of the spectrum of disease. Again, these multi-part questions. I'll be talking a little bit about some of the major principles related to these other conditions, and then we'll address birdshot a little bit separately. I'm just going to show a few cases just to illustrate some of these principles. This is a 46-year-old gentleman with a known history of serpiginous choroidopathy. He complained of a new scotoma involving his right eye. His visual acuity, amazingly, despite this extensive scarring, was 20/20 in both eyes. His immunosuppressive history, he had previously been on Cellcept, but had failed that. He discontinued Imuran and cyclosporin due to some side effects, and recently increased oral prednisone to 80 milligrams a day. The principles related to imaging about how key it is that we're in clinical practice. And so the question is, is this active disease? With serpiginous and AMPI, both of these conditions in the textbooks, they talk about hypofluorescence early and hyperfluorescence in the later stages, but it can be difficult, especially in the course of a busy clinic day, as all of us have, to detect disease activity. But some of the disease features I wanted to point out, the conditions tend to be parapapillary. They have a wavy or serpent-like pattern, again, emanating around the optic nerve. And what's notable is that when you look at his autofluorescence, it's quite clear that he has these areas of the disease in various phases. Again, fundus autofluorescence highlights these areas of disease activity. You can see the areas that were inactive, and you can see these areas that are starting to resolve. And so important to keep that in mind. I find this to be very helpful, especially looking at serpiginous. So it's important to understand the disease phenotype as well as how to follow this disease condition. Moving forward to AMPI, or acute posterior multifocal placoid pigment epitheliopathy. This is a 43-year-old patient, a recent history of upper respiratory infection, decreased vision in her left eye. And interestingly, she reports a similar episode about a year ago in the right eye. And you can see these pigmentary areas of choroidal retinal scarring, just temporal to the fovea, some foveal areas of RPE change. And you see these placoid-like lesions. They're cream-colored, they're deep. Traditional dogma is that in AMPI patients, they may not necessarily need treatment. At least that's what the textbooks still discuss. And as Deborah nicely alluded to, it's really important to think about these various imaging modalities to think about this disease. On angiography, you can see these areas of these hypofluorescent lesions that are hypofluorescent in the central region. ICG can also see these areas of hypocyanescence. Sometimes there can be more prominent lesions than even that we can appreciate by OCT or these other imaging techniques. And what I find really fascinating is when you look at the fundus autofluorescence, you actually see outer retina and RPE disease at varying stages. If you look at the fluorescein angiogram, for instance, you see these areas of hypofluorescence. And you can sort of make this out on fundus autofluorescence, but you can see almost this stippled area of both hyper and hypo autofluorescence. Again, different areas of patchy change that shows this disease really in evolution. And so this is a high magnification view that cuts right through the area of these placoid lesions with overlying outer retinal and RPE change. And you can see, again, these areas of varying disease evolution. On the nasal aspect of the fovea, what you'll see is that there's areas of retinal pigment epithelial thickening, some ellipsoid layer and ELM changes, predominantly outer nuclear change. But as you see this disease in some ways start to improve or resolve, you can see these areas of RPE atrophy and sometimes you can see a loss of ellipsoid layer. But what's interesting is that if you have your ELM and it's intact, sometimes you'll see a return of the ellipsoid layer over time. And there's been some recent literature that's been reported by Amani Fauzi and a number of other groups that have looked at OCT angiography. And one of the underlying questions is related to whether these cream-colored lesions represent areas of just inflammation or these areas that are related to vascular inflammation. Choriocapillaris images have shown flow voids during acute disease. Again, as I mentioned previously, you'll see outer retinal and RPE abnormalities. And some of these areas actually can extend, these flow voids can actually extend beyond the areas of change. So this is an area that I think that warrants further investigation. Again, whether this is related to vascular change or whether these are plaque-like inflammatory lesions. The third condition, again, I'll get through that I wanted to discuss, at least in this segment, is related to MUDES. This is a 45-year-old patient with a 1-week history of decreased vision in the right greater than left eye. She's 2200. The vision has declined in this right eye. She's 20/20 in the left eye. And these patients will sometimes have mild vitreous cell, which this patient had. And you can see the white lesions at the level of the outer retina. Her anterior chamber is quiet, and vitreous is quiet in the left eye. And classically, when you look at the textbooks, the description is that these areas will be hyperfluorescence with late staining or late leakage. And you can see that at 26 seconds, you can see these areas of hyperfluorescence. One of the characteristics is that they'll have these wreath-like configuration lesions around these areas of these white dots. And again, some of the key features, just a reminder that these patients will have foveal granularity with tiny yellow dots at the level of the RPE and outer retina. And the fluorescein angiogram will show that each of these white dots will have these hyperfluorescent spots in a wreath-like or almost halo-like configuration. The natural history, given its obviously its name of being an evanescent white dot syndrome, is that these patients will generally experience improvement over 4 to 6 weeks. I have seen some patients who will develop a big blind spot on their visual field, and some of this will persist. Viral prodrome can be observed, and sometimes with a mild vitritis. So these patients won't have the severe vitritis as seen with other conditions such as multifocal choroiditis and panuveitis. And I find these patients have less inflammation than individuals with birdshot, although obviously there's a spectrum of these conditions as well. Question number 2, which features are classically observed in birdshot retinal choroidopathy on imaging? A, hypocyanescent lesions with active disease on ICG. B, optic disc and retinal vascular leakage by fluorescein angiogram. Or C, cystoid macular edema and atrophic change with chronic untreated disease. Or D, all of the above?
I think it's D.
That's exactly right. So all of the above. So I think, birdshot, I decided to talk a little bit separately, and it's weird to say this is my favorite disease, but I think this is a disease that's certainly of high interest because, at least in terms of disease detection, it's a condition I think that can be commonly missed. Variable phenotypes, but these are some of the distinctive disease characteristics that we'll see, especially in the textbooks. And I think we do see sometimes, not necessarily all of these, but many of these in individual patients as well. So I'll just show this this case. He was a 40-year-old male patient, complained of floaters and debris for 2 years prior to presentation. He had 1+ anterior vitreous cell in both eyes, and so he had had symptoms for about 2 years. And this is what we see sometimes, is that oftentimes these patients will have had symptoms for quite a long period of time. He had been variably diagnosed with retinal tears and other findings. And so those findings were subtle initially, but essentially got worse over time with worsening inflammation. Again, you can see that there is some subtle optic disc edema as well. And some of the key findings that we see in this patient, he had optic disc hyperfluorescence with leakage in the later frames of the angiogram. He also has these areas of, some people will describe this as segmental periphlebitis or vascular leakage, and pretty characteristic hypocyanescent spots by ICG. And he was indeed HLA-A29 positive. Other disease conditions to think about, obviously you want to think about sarcoidosis, syphilis, tuberculosis as other considerations, but ultimately was diagnosed with A29 positive birdshot retinoid keratopathy. And these are very commonly asked from a board's standpoint. Left eye, similar but perhaps more prominent features. You can see his optic disc hyperfluorescence with leakage. Again, this segmental periphlebitis and spots by ICG. And you'll recognize that this is kind of an older slide because I was using cyclosporin. I don't use very much cyclosporin these days, but we ended up treating him with oral prednisone and cyclosporin at the time as a steroid-sparing medication, because I find that sometimes these patients often need immunosuppression to avoid long-term vision loss from either cystoid macular edema, also the potential for photoreceptor degeneration, visual field loss, and ERG dysfunction that we'll see, especially with late phase disease. There are a spectrum of disease findings. I find that OCT is very helpful for these patients as well, although these lesions, especially for their subtle. Choroidal neovascularization is thought to occur in about 3 to 5% of individuals, particularly with untreated inflammation. Some of these patients can develop a vitreomacular or vitreoretinal pathology as well. And these really, the findings on OCT should be correlated with angiography and ICG. And this really depends, how frequently I get FA and ICG really depends on the type of disease that the patient has. I will do annual ERGs and visual fields because these patients can have change both on their photopic and scotopic responses with regards to their B wave and A wave patterns. And visual fields I find very helpful and can be very encouraging for patients if they have a very early form of the disease to ensure that we don't have any visual loss over time. There have been some very nice studies out of Johns Hopkins that have shown the benefit of immunosuppression for birdshot. These are just some case examples. This is a patient with birdshot with cystoid macular edema and underlying photoreceptor degenerative change who had resolution of his cystoid macular edema after Retisert. I find that Retisert does work well for these individuals, as well as the anti-TNF class of medications. This is an individual who had sort of a less common complication, choroidal neovascularization. And so when you see retinal hemorrhage, especially associated with cystoid macular edema, then sometimes an anti-VEGF strategy will be helpful for treating this as well. Which brings us to our last question, question 3. Which feature is not characteristic of acute zonal occult outer retinopathy?
Excellent. So we have my resident, Dr. Ankita Thali from KEM Hospital.
So I think the answer would be B, most common in elderly male patients.
Okay, perfect. We got some sharp trainees on the call today. I think that
Yay.
got them all right today. So that's exactly right. So most common in elderly male patients, because we see this more in young female patients. So that's basically everybody on this call. We're kind of a risk group for that. So in these other features, some of these are actually relatively new, that especially with regards to some of the imaging characteristics, including trizonal imaging, which was recently reported. Enlarged blind spot, it does fall in these big blind spot type syndromes. And certainly these patients will sometimes complain of some very dramatic photopsias and visual sensations that I find when they present to you. And then I think that the challenging thing sometimes is that the patients will come to you and say, yeah, you know, all the doctors that I saw didn't believe that there was something going on because the findings can be very, very subtle. And the good news, again, alluding to Deborah's talk about the importance of imaging, is that these individuals can have very significant findings that can be very difficult to appreciate on fundus photography, and certainly in the course of a busy clinic with fundus photography even sometimes as well. This is a 36-year-old patient who had photopsias and an enlarged blind spot. And you can really see that the fundus autofluorescence is much easier to see what's going on from a pathologic standpoint, an area of central fluorescence with a hyper-autofluorescent border. These are some pictures. This article is from Rick Spade, which showed kind of this stippled hyper-autofluorescence within this hypo-autofluorescent zone. And this area, this leading front, that's sometimes described, and again, normal retina surrounding it. This is a paper by Larry Yanuzzi's group, same group out of New York, where they actually describe this trizonal configuration, this trizonal areas of change that can be depicted both by fundus autofluorescence and OCT. And the way that they've defined it, this left eye actually illustrates it the best. You can see these areas of hypoautofluorescence are correlated with loss of the ellipsoid zone and the ELM. You see this transition zone where all the action seems to be happening with hyperautofluorescence and hypoautofluorescence in this area of normal retina, again with a normal outer retinal architecture and configuration that needs to be closely monitored. So in terms of board questions, this is kind of a busier slide, but I wanted to, how do we think about these conditions in terms of laterality and need for immunosuppression, angiographic features, and fundus autofluorescence? So laterality, again, MUDES we think of as being unilateral. Interestingly, Azor more commonly presents unilaterally, but some of these patients do end up developing bilateral involvement. The bilateral white dots include serpiginous, birdshot, and AMPI. I didn't talk about multifocal choroiditis and pan-uveitis for the sake of time. The question mark relates to need for immunosuppression. Birdshot, the majority of patients I've seen will require immunosuppression. Serpiginous, there's data out of Hopkins that have shown the importance of immunosuppression. In the category of needing immunosuppression less or not needing immunosuppression include AMPI, although there's some discussion about that in recent literature. MUDES and Azor, fluorescein angiography we talked about before in terms of disease characteristics. And again, fundus autofluorescence I find to be very helpful for Azor and serpiginous because of the distinct features with which it presents. And again, multiple imaging modalities, again, using fluorescein angiography for conditions like birdshot, certainly OCT is important for all of these conditions. And I think that this is a very important topic, both for boards and also for a clinical care standpoint, even though we think of these conditions as being on the more rare from an epidemiology standpoint.
I want to open it up to our faculty to chime in with any comments.
Thank you, Stephen. I think that was excellent. I really like that algorithmic approach, sort of breaking it down by steps. You know, as a resident, I was equally confused by this. And I remember Dr. Goldstein trying multiple times to instill it. And it takes a while to get this straight. And I think a lot of it is also just by seeing these patients. And also, not every patient follows the textbook. You know, there are going to be some variation.
Well, to Dilraj's point, actually, patients don't always read the book. Spread hyperotopic news with multifocal choroiditis who get this acute mute spots. So I think it is helpful to categorize things as Stephen has done, which I thought was a beautiful way to look at these patients. But also remember that the patients don't all read the book. These patients are all positive. I've never seen an HLA-A29 negative birdshot patient. I've also never seen a unilateral birdshot. All of those patients have turned out to have lymphoma, choroidal lymphoma or malt cell lymphoma.
Thank you. Stephen, a question has come in through the chat box. How to differentiate Azor from autoimmune retinopathy clinically, as well as through basic investigations?
Yeah, I think that that's a really good question. I think it's a challenging question, especially, you know, with autoimmune retinopathy being such a difficult diagnosis to make. I find these are some of the more challenging category. And I think that we think about these. I mean, when I think about autoimmune retinopathy, I think about what are the really bad things that I don't want to miss. I mean, so that's cancer-associated retinopathy and melanoma-associated retinopathy. And you know, how likely is it to miss a MAR in the absence of known MAR? I think that it would be unusual, but I think it's something that we think about just in general. Just some of the like, big picture thoughts is that AIR, they tend to have, I find to have more bilateral involvement. They can have more diffuse disease. Their ERG tends to be more severe, at least the patients that I've seen in clinical practice in terms of both their rod and their cone or history of with anti-recoverin. People have looked at anti-enolase as another element that's been looked at as well in terms of antibodies. Then I start to think about what we want to do from a treatment standpoint. And really it's following algorithmically with full field ERG and visual field testing. If they have those two areas of dysfunction, then I start thinking about the possibility this may represent an autoimmune retinopathy, again, in the absence of other infectious entities that we want to exclude, syphilis, TB, and the like.
In an interest of time, I'm going to move forward to Dr. Graywall. He did his residency at Northwestern, his vitreoretinal fellowship at Duke University, and he went on to complete the Uveitis Fellowship at the Morrisfield Eye Hospital and stayed on as faculty at the Duke Eye Center. He is the recipient of the Heed Ophthalmic Foundation Fellowship Award and the Senior Achievement Award from the AAO. He's recently been inducted into the prestigious Macula Society and the Retina Society. I am delighted to have him here to give us What's Hot in Uveitis 2019 to 2020 publications.
Before I delve into it, just wanted to point this out that this year, 2020, we've had over 1,500 publications in uveitis. But what is very encouraging is if you look at the graph over the last 15 years, it's been an exponential increase. And I think the year's not over yet. So you can see, I'm pretty sure that 2020 will outpace all the prior years. So this is very encouraging. It's also a testament to the growth in our field, both in terms of diagnostic investigations as well as therapeutics. And I would encourage all trainees who are interested to strongly consider pursuing a career in uveitis. So let's jump right into it. I'm going to keep this relatively short. So this first paper is out of Spain, and this is a nice nationwide study where they looked at the drug retention rate and causes of discontinuation of adalimumab. And this is basically real world data. So at the end of 5 years, over half of the patients were still on adalimumab therapy with overall a good safety profile, and that's encouraging. There was, amongst the main reasons for discontinuation were lack of efficacy in about 48%, adverse effects, which are about 22%, And interestingly, almost 17% of them were able to discontinue treatment because of disease quiescence. So I think figures like these are very helpful when we are talking to patients, in addition to the clinical trial, the registration clinical trial data, that there is an endpoint in sight for treatment. Similarly, this is the long-term safety and efficacy data from the Visual 1 and Visual 2 trials when these patients were observed for up to 7 years. And interestingly, again, 80% of patients in the active group and over 96% in the inactive group were quiescent at year 3. That's week 150. And similarly, the adverse events were relatively low, and the risk of serious infections was about 8%, because that's often a main discussion point with patients, is the risk of infections and the risk of neoplasms in patients starting biologics. So this gives us some good data to talk to patients about. The FAST trial was it's been a large trial that has produced a lot of important publications. And this is a very useful outcome of comparison of methotrexate with mycophenolate or Celsep. These are two of our commonly used antimetabolites in treatment of uveitis. So they looked at 265 adults. And overall, the treatment success was about 67% in methotrexate and 57% in Celsep. And this is also an interesting paper that is going to be more and more relevant as we are entering the era of increasing use of biosimilars. And some of this usage of biosimilars is being mandated by insurance companies. We're seeing it in other diseases, but it's also increasingly seen in uveitis. So there is a biosimilar available for infliximab. And this was a study out of Cleveland Clinic where they looked at 17 patients who received this biosimilar. And they found that overall, there were more flare-ups defined in terms of per person years on the biosimilar versus the original drug, that is Remicade. And also the patients who had these flare-ups required a higher dose of biosimilar to control the flares compared to the original product. And I think this is going to be of increasing interest as we are seeing, for example, rituximab being available as a biosimilar and there being a requirement to initiate biosimilars as a first-line treatment. Dr. Goldstein and Anjum published this paper on the clinical features in TINU. And this was very interesting because I had always thought of TINU as being more of an anterior uveitis phenotype. And almost 20% who had multifocal choroidal lesions, 40% with disc edema, and almost a fourth with some sort of vasculitis. And it suggests that this is a much more severe type than what we traditionally think it to be, acquired systemic. This was a interesting cohort-based study from the Scandinavian countries where they followed patients with JIA, and there were almost 450 patients that were followed prospectively for 18 years. And this was important because about 22% of patients developed uveitis eventually during this 18 years of follow-up. But out of these, almost 3% were diagnosed after 8 years of their JIA diagnosis. So at the year 18 visit, there was active uveitis in almost 1/4 of patients. And that's quite a high number. But interestingly, only 5% of patients had a binocular vision of less than 20/40. And they concluded that uveitis screening should start immediately after the diagnosis of JIA is established or suspected and should continue more than 8 years after the diagnosis. And this may be different than what our current guidelines are. And it suggests that there may be a value in revisiting our screening guidelines for JIA. And it also gives you data to tell you that the disease may persist with up to 1/4 of patients being active at 18 years. This was a paper from the SITE group, and they looked at factors that were predictive of remission or chronic anterior uveitis. So they had over 1,600 patients who had anterior uveitis that was active for more than 3 months. And they defined remission as uveitis being inactive off of treatment for 3 months. Observed a cumulative remission rate of about 33%. So that means that 2/3 of patients were still active. And the factors that were predictive of lesser chances of remission included a uveitis duration of more than 2 years, bilateral uveitis, undergoing prior cataract or glaucoma surgery, and a diagnosis of JIA or other spondyloarthropathies. This was a very interesting paper, and this has been the subject of several research papers over the last few years, not just in uveitis, but in other ocular diseases as well. And that relates to the levels of vitamin D. So these were 151 patients who underwent measurement of their vitamin D level. And they found that in patients who had active uveitis, the levels were lower than those who were inactive, and also those in the regular population who did not have uveitis. And they found that this difference held true even after they excluded those with inflammatory bowel disease and sarcoidosis, which are both associated with vitamin D deficiency. They also found that sun exposure and vitamin D supplementation were associated with uveitis inactivity. They suggested that this supports the role of vitamin D deficiency in autoimmunity. Now, this is a topic that's still a little controversial. I think Dr. Sobrin wrote very nicely in a commentary in this paper that there may be an effect of reverse causation as well, that patients who have active disease because of light sensitivity may tend to avoid sunlight. But there have been similar associations also reported from large and claims-based databases. So this is going to be an interesting topic as we learn about it more. There was also a follow-up study from the MUST trial, and they looked at patients in relation to their cystoid macular edema through 7 years. And they found that over 90% of eyes had CME that resolved at some point during their 7 years of follow-up, but about 40% had recurrence. And if you look at these graphs here, you can see that the time to resolution in most of the patients is within a year, but you can continue to see resolution even up till year 6 and 7. Found that patients who had epiretinal membranes had a lower likelihood of CME resolution, and that suggests that there may be value of looking at epiretinal membrane removal in these eyes with chronic CME. And interestingly, even in eyes with chronic CME, those in which the CME resolved gained about 6 letters, and those in which CME recurred lost about 9 letters. And I think this is valuable because we often look at patients who have chronic CME and may not be as aggressive in treating them because of the chronicity, but this data suggests that there is value and potential for vision improvement even in the long run. And I'll let Dr. Vishali talk about this in more detail, but she's really, and she along with the COTS group are really the world's authority on ocular tuberculosis. And this is a source of a lot of confusion often for uveitis specialists along with infectious disease, and there's often disagreement in terms of when to institute treatment, particularly in the absence of radiographic findings, which is often the case. So this was a consensus group with 81 experts that comprised ophthalmologists, pulmonologists, and infectious disease physicians. And they agreed on initiation of anti-tubercular treatment in the presence of tubercular choroiditis. So when there is the presence of positive results from an immunologic test, whether it's the PPD test or quantiferon gold, but you also wanted to see radiologic features suggestive of TB. It's with the tuberculoma, like you can see in the image in the top right, and tubercular serpiginous-like choroiditis, there was recommendation to initiate anti-tubercular treatment even when there were no radiologic features detected that were suggestive of tuberculosis. And I think that's important in our practice patterns. They also looked at a similar kind of consensus agreement in patients who had anterior uveitis, intermediate, pan retinal vasculitis. And the general consensus in that cohort was that you required radiologic confirmation of evidence of tuberculosis to initiate treatment. If you had no radiologic confirmation or it was not performed, then there was no consensus achieved. There was a workshop on ocular sarcoidosis, and this is also helpful to management of posterior uveitis. And again, similar to what we see in clinical practice, it demonstrates that the need to be more aggressive when you have posterior involvement, with first-line therapy being steroids or immunosuppression along with local steroid treatment. And it also is very helpful to have drugs as guidelines for the management of ocular sarcoidosis, along with clear guidelines for the duration of systemic steroid use. There was also the 3-year results from the sustained release fluocinolone acetonide insert. And this was the clinical trial, the registration clinical trial. There are 87 eyes that were treated with this insert, which is designed to release fluocinolone in a sustained release manner over 36 months. And 42 eyes that were sham treated. And overall, they found that there was a reduction in recurrences. But even despite that, over 60% of eyes that were treated with the fluocinolone implant had a recurrence over 3 years. There was a substantial reduction in adjunctive treatment. About 74% of eyes who received this implant needed surgery by the end of 3 years. And so this is important when you discuss this implant with patients, that there's about 3/4 chance that they were going to require cataract surgery at the end of 3 years. The rate of severe IOP elevation requiring surgery is much lower with this implant compared to the surgically placed fluocinolone implant. And I think this is an interesting implant that we are learning more about its efficacy, especially by the disease phenotype, because that was not something evaluated as part of these phase 3 trials. Dr. Ye published this paper on the outcomes of systemic and intravitreal therapy. And we discussed this earlier this morning about the preferred practice patterns and the value of adding local therapy. And they concluded that the combination of intravitreal and systemic antivirals improved vision and limited retinitis progression, additional attachment by over 2-fold. And again, as Dr. Acharya discussed, there is the main importance of systemic treatment is fellow eye involvement, and there was no fellow eye involvement after the systemic treatment with antivirals. And only less than 10% of eyes had an additional quadrant involved after treatment was started. There were a few papers that were published on uveitis diagnosis, on enhancing our ability to diagnose uveitis using ocular fluids or even blood samples. And I think this is very interesting as we move into improving the or assigning a distinct diagnosis to uveitis and reducing that 50% cutoff that we often use for idiopathic. So they looked at infections, and they had a direct strip PCR where they were able to rapidly assess for 9 infections, and that include HSV1, HSV2, EBV, HTLV, VZV, HHV6, CMV, toxo, and treponema pallidum. And the value of this test is it can be performed very quickly in less than a minute, and it only requires 0.02 cc's of volume. And that's a significant advantage because oftentimes it's harder to achieve a large enough volume, especially in the clinic, to test for multiple pathogens. And it was also used for intraoperative rapid diagnosis of infectious uveitis. And interestingly, in Japan, they have been using this quite widely for the last few years. And reducing the cost and the time, I think, is going to be an incremental step forward. And they found that it had a very strong correlation with that traditional quantitative PCR. This was a paper where they looked at RNA sequencing in peripheral blood. So moving a little bit, moving away from ocular samples and even potentially being able to look at blood samples. And they looked at 4 phenotypes. So spondyloarthritis, sarcoid, inflammatory bowel disease, TENU, and idiopathic. And they found that overall, there was an 85% accuracy in RNA sequencing just using peripheral blood samples to achieve this diagnosis. Again, along the lines of advancing proteomics in uveitis, this group out of Stanford looked at whole exome sequencing, and they tried to identify potential uveitis susceptible factors to see if you could diagnose non-syndromic uveitis in those patients who had a known variant for a syndromic inflammatory disease. And they found these 4 variants that were suggestive, that were correlated with uveitis. And all of these variants have been previously reported in literature to be inflammatory. And this implicates this inflammasome in posterior segment uveitis diagnosis. And again, I think as the cost comes down and the technology becomes more widely available, we're going to see an incremental advance in our diagnostics. This was an interesting paper. I think this speaks to our discussion with Dr. Ye about white dot syndromes and how some folks may be lumpers and others splitters, but they used a cluster analysis approach for differentiating multifocal choroiditis and punctate inner choroidopathy. And they found that peripheral lesions and intraocular inflammation were distinct clinical phenotypes of multifocal choroiditis compared to PIC. And I think, again, as we use more advanced image analysis and potentially machine learning techniques, we may be able to pick up some of these differences. And finally, there has been a lot of work and commentary on managing uveitis during the pandemic. I think the general consensus is to continue immunosuppression and obviously manage each patient individually. And with that, thank you.
Raj, thank you so much for taking up the mountainous effort of putting that together for us. It is no small task, and I thank you for doing that. To be brief, just a quick shout out first to Dr. Sanjay Patel, who is just finishing up his term as chair of Mayo Clinic. He's with us in the audience, but he was actually part of Transplant Innovations 2020. So Sanjay, thank you so much for being with us. I want to open it up for three of our faculty, Tinu, Arn, and then Dr. Acharya on the must uveitic macular edema. So Dr. Goldstein, to you first.
All right, well, thanks, Dilraj. Thanks for including our Tinu paper. I think it's a really important point. We have tended to think of Tinu as bilateral acute anterior uveitis because that's the original phenotype that was described. Therefore, those are the patients in whom we look at urine beta-2 microglobulin. It was also first described in young patients, actually in young Asian females, but as we look, we see that it's actually, if anything, more common in males. Certainly in looking at my patients with Tinu, I found that, as Dilraj said, an extraordinarily high number of them have posterior segment involvement. We just saw a new patient this week in whom I am sure the workup will be positive for Tinu. So I think it's important that we expand the features of what we're looking for. Certainly the posterior segment disease is what has required immunosuppression for longer periods, and that patients with acute disease but present with a more chronic picture will also turn out, we won't find out if we don't look. And I don't know what else to say. Thank Dilraj very much for his fabulous talk. Unfortunately, I'm going to have to leave in a couple of minutes to go pick up my daughter at the airport. So thank you so much for organizing this fabulous course. It was really a pleasure to be included.
Dr. Goldstein, thank you so much for being with us and giving us so many pearls. We look forward to having you time and time again with us.
My pleasure. I'd be happy to.
And have a great day with your daughter.
Thanks. I'm really excited. Bye, guys. Thanks so much, everybody.
Bye, Dr. Goldstein. So, so we are going to ask for brief comments from Dr. Yi regarding his paper and Dr. Acharya, and then we're going to move to our finale speaker, Dr. Vishali Gupta. So Dr. Yi, over to you.
Yeah, first, Dilraj, really great summary of, I mean, just so everybody's down and submitted and published. I would say that just the 2 points that I would make with regards to this population is that we did as Dilraj mentioned, we saw this direct, this relationship. There was a 2.2-fold increase with every additional quadrant involved, and really speaks to the importance of early aggressive antiviral therapy given locally to try to reduce that risk. As Dilraj also mentioned, that the patients who were started on systemic and intravitreal tended not to progress. But if you add up the different quadrants, by the time you get to 3-quadrant or 4-quadrant involvement, we're talking about a 25-fold increased risk of retinal detachment. It really speaks to not only early medical intervention, but I think that the other questions that really come into play, and then we have cancer. Great talk, very thorough and complete.
Great comments. Dr. Acharya, over to you.
Yes, and I think you were interested in the MUST trial paper, right, on the 7 years?
Yes.
Yeah, so, I've been following, we're a participant in that trial, your data, and I found that systemic visual application. Macular edema specifically, I think that we see that there's an issue of just persistent recurrent edema, which is very common. And that is present, even with successful treatment of adjunctive, probably local therapy or escalation of systemic therapy in order to address macular edema. It's not something that just goes away and stays away, unfortunately.
Beautiful, beautiful. And we are going to move forward. But before that, Dilraj, what was your favorite paper from all the different papers you saw? And went through?
Personally very excited about the diagnostics. I think we are really pushing the envelope now and starting to get some answers because, as you know, it's a source of frustration both for the patient and for us. And I think a combination of all of sampling from the eye, plasma samples, advanced exome sequencing genomics, the targeted therapeutics.
Superb. Thank you for that, Dilraj. We are going to move forward to our finale speaker, Dr. Vishali Gupta. Dr. Gupta is the professor at the Advanced Eye Care Center Postgraduate Institution of Medical Education and Research in Chandigarh and has trained approximately 80 fellows. She is the president of the Uveitis Society of India, was the secretary of the Vitreoretinal Society India, and has brought together more than 80 experts from 25 centers in the field of uveitis to form the Collaborative Ocular TB Study, COTS. It is absolutely perfect that she is our finale speaker to give us TB everywhere, tuberculosis multiple choice questions. So Dr. Vishali, over to you.
Thank you. Thank you, Ashiana, for the very kind introduction. I know it's late in India, so I'm going to move straight to my questions. What is true about intraocular TB? A, it does not affect vascular structures of the eye and mainly causes scleritis. B, choroiditis is the only manifestation of intraocular TB. C, TB has protean ocular manifestation and can involve any part of the eye, and it could be immune-mediated or infective disease process. And D, TB could be caused by transconjunctival inoculation of mycobacterium and may present as acute conjunctivitis.
Wonderful. So we have Shankar Netralia Fellow Dr. Ghazal Patnik. Dr. Ghazal, if you can give us your best guess on this question.
Hi, ma'am. As if now it is C, TB has a protean ocular manifestation that can involve any part of the eye, and it could be immune-mediated or infective disease process.
Wonderful, Ghazal. That's the correct answer. So let's see what all TB can produce. Now, these are some of the phenotypes that I have mentioned. And uveitis, where you can see the nodules. You may see nodules at the border. Now, if you see in this stroma, these are Busaka, these are Kopis nodules, broad-based posterior synecdoche. The synecdoche that have a broad-based, these are some of the phenotypes that we reported had a very high positive predictive value of being associated with TB and of these broad-based posterior synecdoche. So if you see them, think about TB. Then comes intermediate uveitis, and I would like to give you a practical tip here. If you see large floating snowballs and you're not seeing the classical snow banking, and there is a lot of anterior segment involvement along with it, think of TB as a phenotype. Chronicity, large slow balls, and no typical snow banking. Coming to retinal vasculitis, just be mindful that TB itself doesn't cause retinitis except 2 case reports in literature. By and large, the vasculitis is occlusive in nature, and that is the hallmark of TB vasculitis. And second is, you may see these perivascular choroiditis patches either in the same or in the opposite eye. So these are the 2 features which we found to be very, very specifically with high predictive value associated with TB. Then comes the choroidal involvement. You all know tubercles. You may see tuberculoma, and you may see large abscess. And these are the variants which may have associated systemic disease, and these could be multibacillary. Finally comes TB serpiginous-like choroiditis that we described in year 2002. It tends to be unilateral, may have associated inflammation, and unlike what Stephen showed beautifully, the classical serpiginous beginning near the disc, this one is in the posterior pole. And you may have pigment clumping at the center and the lesions advancing along the edge. So this is again to show you how these 3 lesions have found to be very, very specific with a good post-test probability of having them to be TB. Moving on to next question, how to investigate intraocular TB? A, only clinical phenotype is enough, you don't need lab. B, confirmed diagnosis is important before you can initiate therapy. Therefore, you should get the intraocular biopsy, PCR, smear, culture. C, would look for active pulmonary disease by CT chest, sputum testing. D, will look for corroborative evidence of latent TB by doing immunological tests like PPT, quantiferon gold, and CT chest. And E will do a whole body PET scan first to look for any extrapulmonary disease.
Beautiful question. We invite Dr. Amol Sura from UCSF Uveitis Fellow, to give us his best guess on this question.
D. Look for, get the PPD, quantiferon, and CT chest.
You guys know a lot of TB. Wonderful. Yes, the answer is D. And why? Because I would just like to show you a couple of slides that pathogenesis is very different in different phenotypes. If you are looking some of these phenotypes like serpiginous choroiditis or vasculitis, these are immunologically driven. There is paucibacillary disease because it is just one or two bugs sitting somewhere between the RPE and Bruch's membrane, which are inciting the immune response. So it's a kind of an immune-mediated disease, and it's a delayed hypersensitivity reaction, and these are the phenotypes: serpiginous, vasculitis, anterior, and intermediate uveitis, where you don't have the eye teeming with bacilli. So this is the question which everybody generally asks. If it is an immune-mediated response in majority, then why the hell we need to give anti-TB treatment, or do we actually need active tuberculosis to make the diagnosis? And the answer is no. You should not be looking for active disease in the lungs, because more than 90% of the times you will not find it. This is the COD study, and thanks Dilraj for mentioning it. Before making the consensus, we had data collection, real world data, and just the salient features were that there is no evidence of systemic TB in more than 90% of the patients. So don't really make it, the pulmonologist would always want to look for active TB, but as an ocular specialist, you should not. Posterior uveitis is a very common phenotype, and it is SLC most of the time. But very important is Monteus is positive in 87 and TB cold in 89%. So most of the experts from all over the world still rely on these basic tests. PCR is not commonly performed or trusted. Maybe we don't have a standardized PCR for TB. Chest X-ray is not as good as CT chest, because CT can pick up the old exposure in 68% compared to chest, which is only 26%. Coming to third question. Now we know the phenotype, we know the diagnosis. The third is we have to start anti-TB drugs. So what would be the criteria for initiating anti-TB drugs? A, based on the clinical presentation alone, especially if the patient is from endemic region, decision shall be based on combination of factors like the region of endemicity, clinical phenotype, immunological, and radiologic test. C, only if you have the histological confirmation of the diagnosis. And D, there is no need to initiate anti-TB because most of the time the disease is immunological and responds very well to corticosteroids.
Good evening. I'd like to go with B, the decision based on the combination of factors such as the endemicity, the clinical phenotype, immunological and radiological tests.
Absolutely right on the spot today. And this is what the COTS consensus was all about. We took into consideration the phenotype, the endemicity, whether the disease was first episode, was it recurrent, was it active, was it inactive? And then we took into consideration PPD skin test, radiology, IGRA, like a combination of these, one of these, two of these, three of these. And we generated total 486 questions and came out with, it was an exhaustive process, Delphi 1, Delphi 2, expert meeting and all. And this is the kind of the scale on which different experts reported. So I won't go into much. I'm just going to give you example of it in choroiditis, because serpiginous is the most important phenotype that responds. The other information can be obtained. I would just show you the references. So this is what experts agreed on regarding the choroiditis. Scenario 1, which was Delphi 1, was serpiginous-like choroiditis, whether the patient is from endemic or non-endemic region, if both immunologic tests, that is PPT and ECRA, and one radiology test is positive, everybody would treat. Patient from both endemic, non-endemic region and 2 immunological tests not available by majority, more than 85%. Third, the patient with SLC both from endemic and non-endemic region with 1 immunology and 1 radiologic test positive, still experts would treat. Then we go to Delphi 2, where there were some controversies, and the results of the Delphi 2 with patients with SLC both from endemic and non-endemic region with 1 immunological test positive. If the phenotype is serpiginous-like choroiditis and very typical, they would treat. These scenarios are not much different, only difference is that experts from endemic rely more on PPD, whereas non-endemic would rely on IGRA. For other phenotypes also, there is a clear-cut consensus, and I would refer you to these publications in ophthalmology, both the reports, for more details. Coming to the last question. What is recommended therapy for patients with TB SLC? A, 4-drug anti-tuberculosis therapy only, so why not treat with anti-infective agents? Like B alone, as the patient does not have any systemic disease. C, anti-TB drugs with corticosteroids, as corticosteroids shall take care of the immune response on the short-term basis, and the TB will help in reducing recurrences in long term. And D, biologics to take care of immune-driven response.
Beautiful. So I am going to call on Dr. Caroline Minkus. Dr. Minkus, would you like to give your best guess on that question?
I would say C, the anti-TB drugs as well as steroids.
Absolutely, absolutely right. So C is, and this is the answer to all that many times you would be asked, why combine the 2 treatments? It's an immune-mediated disease. You've got to take care of that immune response. So you got to give steroids. But the bug, the inciting bug is Mycobacterium. So you need to take care of that bug, because otherwise it will keep on causing recurrences again and again. So why corticosteroids? I already answered. You need to take care of inflammation and need to look for the clinical biomarkers actually, which will help you differentiate between palsy and multibacillary disease. And I have already shown you the disease which is immune-mediated phenotypes would need corticosteroids. Be careful, and I showed you that you do have the abscesses sitting there. You do have large granulomas. These are the kind of the TB, which is multibacillary, which is not immune mediated, where the bugs are actually multiplying. So these are the kind of the patients you have to be very cautious in using corticosteroid. And you can see, unfortunately, this patient has received Ozurdex in this eye, which is a kind of a death sentence for these eyes. But if you see these kind of eyes, immune mediated, you have to treat, because if you give anti-TB alone, you end up in a situation like this, which is a kind of paradoxical worsening or immune recovery or whatever you call it. So be very sure that they are under very good cover of corticosteroids. So we did raise this question in our consensus, and all the experts agreed to consensus for concomitant use of corticosteroids in immune-mediated phenotypes to prevent the paradoxical worsening. And also, if at any stage in patients with retinal vasculitis or even choroiditis, you feel that you are unable to wean off the corticosteroids, stations in the eye, and most of the times the patient will not have active concomitant pulmonary disease. So you got to tell your pulmonologist that, friend, if the disease is active in the eye, it is active. You don't care whether it is active elsewhere in the body. Don't call it a latent disease because it's active in the eye. Anti-TB drugs are needed to treat active eye disease with an aim to reduce recurrences. And since most of the phenotypes, except the large tuberculomas and the abscesses, are immune-mediated, it's important to add corticosteroids. That's what is written after you rule out the presence of large granuloma or abscess in the eye. Thank you very much, and thank you, Ashiana, for the opportunity given to me.
Dr. Vaishali, there couldn't be someone more greater and expert in ocular TB on this earth than you, I believe. And so it is an honor to have you. There is a question that's come in for you, Dr. Vaishali. Is there a value in initiating anti-tubercular treatment in patients with latent TB who have non-ocular TB uveitis in anticipation of starting oral steroids or immunotherapy, i.e., what is the relative risk of reactivation with immunosuppression?
It's 10%. If the patient has latent tuberculosis and you start something, then there would be 10% risk of progressing to active disease. But if, God forbid, you're planning to start biologics, then that risk is very high. So like in other rheumatology practices, if you're planning to start long-term immunosuppression or biologics, your internist will anyways treat the latent tuberculosis by giving medicines, and biologics we generally delay for 1 month. 1 month cover of anti-TB drugs, and then proceed or start biologics. And if it is just a latent TB, with say HLA-B27 phenotype, you can. If you feel the need for long-term immunity, it's important to give the cover of anti-TB drugs in consultation with your internist.
Beautiful, beautiful. Any comments from the faculty or any questions? Starting with
Dr. Vaishali, I have a question. How would you distinguish that it is a paradox worsening or a drug resistance?
Paradoxical worsening generally comes at a very typical time when you have started anti-TB drugs, and it's 2 weeks, 2 to 3 weeks after starting the anti-TB therapy. And the moment you give steroids, local methotrexate, steroids, systemic, it starts disappearing very soon. The drug resistance will generally, because TB drugs take about 6 weeks to act. So the drug resistance is generally soon 2 weeks, even if you have started a wrong treatment or even if the patient is not responding. So even if the patient is not responding, you have started anti-TB drug, it will not progress like hell in 2 weeks, you know? So the drug resistance is something that patient is not responding, but it will be very slow progression, and you will realize that when by 2 months, 3 or 2.5, 3 months, your patient is not responding the way you would expect a response. But this one, paradoxical worsening, is 2 weeks and the whole thing goes like on a forest fire kind of a thing. So it's very different compared to drug resistance, the timing.
So basically we are looking at the immune part of the TB disease.
Immune, mostly the immune ones.
Mostly the immune. We're not thinking about the multivascular phenotypes.
Because multibacillary could be progressing as such, so there we cannot differentiate between the two, and neither do we. Yeah.
Exactly.
Beautiful. Any other comments from the faculty?
No, I personally, I just wanted to thank you for all the efforts behind COTS. You know, it really helps to simplify, and I think we all struggle with this, and getting the evidence there really helps to get the infectious disease and pulmonology team.
I have just one question for Shali. Really, really wonderful talk, and really think about this population of patients and the challenges associated with it. Just from an epidemiology standpoint, and I apologize, I don't know everybody's in that working group. That's fantastic. Is the epidemiology, especially with multi-drug resistant TB in different populations, I imagine other countries are going to be looking to you guys for guidance on that. Are you seeing that more epidemiologically? Just in aggregate from a public health standpoint, either in India, or are you hearing other things from other countries, prison populations and such?
We have about 4% of our pulmonary disease. For ocular TB, we are not seeing patients with active pulmonary disease who have the disease in the eye. Most of the time, we are seeing patients with latent tuberculosis who have the disease in the eye. So it's very rare to find drug resistance in the eye. The only situation where we see drug-resistant tuberculosis in the eye is the patients who have active focus somewhere else, pulmonary, extrapulmonary, and we have this huge abscess-like thing sitting in the eye, which could be drug-resistant, but which could be simply because of the fact that many of the drugs that we are giving, we do not know their minimum inhibition concentration in the eye. So they are from the ocular samples, and we do them for rifampicin resistance now. And it's just 0.1% of the total. So we don't find it very frequently. That's not a huge challenge, honestly. It's once in a blue moon you see a situation like this. Paradoxical worsening, on the other hand, we see nearly 40% of the patients. And when we do the ultra wide field, you realize that sometimes it's happening in the periphery. And that was happening because when we think of TB, we were very hesitant to give a full dose of steroids. Like we would start 30 milligram, 40 milligram. And that's the time when we were having paradoxical worsening. But once you know and you go 1 milligram per kg or Ozurdex, it doesn't happen. It's under control. Thank you.
Shali, that was really excellent. I just want to applaud all the work that you've taught all of us about ocular TB. We learned from your experience. I wanted to just pick your brain on this. We have a number of patients at Proctor where we are calling them TB serpiginous patients, often for 12 months even. But we're finding that a lot of them need escalated immunosuppression beyond steroids because they keep on having progressive lesions. Quite extensive progression. And I'm wondering how often and how far you take extra immunosuppression. And, do you ever give local steroids in addition? We've gone through multiple immunosuppressive agents, and it's a little scary.
Nisha, is that progression happening in the first 2 months?
No. So these are patients that are long-term patients where not just the initial worsening that you see, but long-term, even after a year or more. They're even
if it's ongoing, then probably it's not TB. Then probably these are the patients who need to be on immunosuppression anyways. Because 20% of the patients, even in cohorts, when we analyze the data, they would continue to progress. And we have some of those patients, those who have a very dark yellow border, they're more of a placoid variety, and they just keep on progressing, whatever you keep on doing. But in my experience, ultimately they respond to Ozurdex. And they are kind of Ozurdex addicts. You keep on injecting one after the other for many years, but that's what keeps them going. And we have tried to look for every possible thing. We have even treated them for those atypical mycobacteria because some PCR from the ocular sample came positive. So we started giving them, but it doesn't work. Only thing that works in the end is Ozurdex. So I would not be treating them with TB. anymore, more than 9 months, though the
Right. Yes. And I think we've been escalating immunosuppression quite a bit in these patients because we figured we've adequately treated them, but they seem to need ongoing treatment.
Absolutely.
So that's interesting. That's been your experience in that you used local steroid injections so much.
When we are following up these patients and again they come with, we've given one complete
do.
course. So the next time, 2 years later when they come, so we are just treating them with immunosuppression.
Unless there is like this girl from New Delhi the other day was not responding, scan, and then there was something happening in the parotid. We took the biopsy, they reported as Watkins tumor. We requested them to look at, and then there was this TB of the parotid gland. So sometimes some of these things which are a focus hidden somewhere in the body which has not responded to first time therapy, because there are so many regimens and, you know, where we feel the first time treatment could have been inadequate only in those exceptional cases, but otherwise for the ocular point of view, mostly no. Especially if it's an immune mediated phenotype, mostly never. Just treat it with immunosuppression.